Good afternoon, ladies and gentlemen. A warm welcome from Indian Medical Practitioner Association, my CMD branch. Now, we are about to start by about 2 o'clock. One of the speakers from Apollo is doing a surgery now. The first speaker. I'm a little late. He may or may not come, but we do not know. But we'll finish off the second speaker first, and if he's coming, we'll continue with the speaker. So, and of course, we have one excellent speaker also. Luckily, he happens to be a friend of my very close friend, Dr. Senthil Kumar Ganapathy. He is going to talk today on. We all know about laparoscopic surgery. For many of these colonic diseases, laparoscopic surgery is the order of the day. But now robotics have come into it, and how robotics can help us to. In fact, robotics can really precisely find out where exactly is problem, remove that particular problem. So on that particular aspect, he is going to talk on how robotics are going to replace laparoscopic surgery and what are the common anorectal problems and how a general practitioner should approach it and when to refer the case for the specialist. So Dr. Senthil Kumar Ganapathy is here to do the thing. May I request Professor Subhashini to introduce Dr. Senthil Kumar Ganapathy. Madam, over to you.
Good afternoon. It gives me a great pleasure to introduce Dr. Senthil Kumar Ganapathy now. He got his MS General Surgery from Madras Medical College, MRCS and FRCS from UK, and he's also a fellow of Association of Colorectal Surgeons. And he got his MD research from London. He is a senior consultant in gastroenterology, Apollo Proton Hospital. His areas of interest is mainly managing colorectal cancers by minimal invasive techniques for the past 20 years. And he is also doing robotic surgery for the last 8 years. And apart from colorectal surgeries, he does IBD surgeries, abdominal hernia and other things. See, when I was a student, laparotomy is the only diagnostic as well as a curative part. They used to do diagnostic laparotomy. So without knowing what is going on inside the abdomen, they will be opening the abdomen. Later, when I was assistant professor, the laparoscopic surgeries came. Now, the robotic surgery has come, still more advanced one. So now he is going to talk about the robotic surgery replacing laparoscopic surgery. I invited Dr. Senthil Kumar Ganapathy. Thank you.
Thank you very much for the nice introduction, madam.
You want to answer the questions then and there, or ask questions then and there, or?
Yeah, I would like this to be an interactive session. So anybody who wants to interrupt and ask a question, they can just ask it then and there, so that we can clear everything as we go along.
As senior citizens, we tend to forget.
No, I'm also slowly becoming a senior citizen. I think from the way both of you were talking, you have already decided that robotics has replaced laparoscopic surgery. In fact, my topic is robotics replacing laparoscopic surgery? I put a question mark. You have already decided that it has replaced. So while they are connecting, let me just ask a question to the esteemed audience. How many of you think that the robotic surgery is a automated or at least a semi-automated surgery? Yeah, yeah. So I don't think we can call it even a semi-automatic, madam, because each and every step, none of any steps are automated. Every step is controlled by the surgeon on the surgeon's console. So I am not at the patient bedside to do the controlling, but I am at the surgeon's console from where I control everything. So not even anything moves without the surgeon moving things. So nothing is automated, not even semi-automatic. Of course, a lot of artificial intelligence we are using for the robotics as well. For example, when we use a robotic stapler, it doesn't staple and cut if the tissue thickness is too much. It senses this is too thick a tissue to cut, so it will say no, this is not the appropriate stapler for firing, and then we have to change the stapler accordingly. So என்ன பண்ண போறேன், வேற ஏதாவது கனெக்டர் வேணுமா? இந்த கனெக்டர் ஒர்க் ஆகலையா?
So what is artificial intelligence? Everybody is talking about it. What is artificial intelligence? Because I'm 72 years old, I don't know. Let me be frank. What is artificial intelligence?
Because certain things or a certain kind of intelligence is built into the system, where the stapler, without any of the surgeon's inputs, the stapler itself, through the robotic system, it senses that this particular cartridge is the size does not fit this particular tissue, so it rejects cutting the tissue and it tells us that we have to use a bigger sized cartridge. So this is the kind of intelligence which is built into the system, but it doesn't fire without my firing. It just tells me, just gives me the information.
Some job for you.
It is doing definitely doing some job for me.
Who has destroyed this intelligence?
Intelligence is it's a man-made. No, artificial intelligence is all man-made. But in that particular surgery, we have made the surgery easier because it is sensing all those intelligence. Because I don't need to go inside just to touch the tissue, see how thick it is. Because in robotic surgery, I am not able to touch the tissue. So all that has been built into the system. Previously, they used to say that because you can't touch, laparoscopic surgery is not going to take off too much because you don't get the tactile feedback. Then we got the feedback through the laparoscopic instruments, and by way of training, they got the feedback. And then in robotic surgery, that's an even bigger criticism that you don't get any tactile feedback because I'm sitting on the surgeon's console and the patient is there 10 meters away from me. So how do I feel when I'm touching the patient's tissue? I think with experience, with the visual feedback, I can see visually how much tension is there when I'm holding a particular tissue, and using the visual feedback, I'm able to compensate for the absence of tactile feedback, and over a period of time, this absence of tactile feedback is not an issue at all.
So obviously, then robotic surgery is far more superior to laparoscopy, where human is doing the job, where you have an extra intelligence with you.
This intelligence can be built into laparoscopic stapler also. So nowadays, even the laparoscopic staplers, they are making it with this kind of intelligence where it refuses to fire if the tissue is too thick or too thin, like that. So this artificial intelligence is not just alone for the robot. It can be built into anything. Certain laparoscopic applications also can use artificial intelligence. Yes, madam.
This will be your command.
You mean the robots? Disobey means sometimes it can get frozen. In the sense, if the robotic arms are clashing too much, then it stops working. Then I have to see why it has stopped working. Then I go near the patient. The arms are clashing. The arms, I have to separate them a little bit more so that they are not clashing with each other.
So accident appears in the field.
Accident.
Part of the arms.
Accident, but certain safety features has been built into the system where it may not move, but it will not make a movement that I have not ordered it to. If I am not making the movement, it will not automatically, it might freeze and stop moving, but it will not move by itself.
Suppose there is a dream.
Yes.
What you are asking it will it obey? If it doesn't obey, then it's a problem.
There is no issue of the robot obeying us or not. I have to just use the robot efficiently to stop the bleeding, just like open surgery or laparoscopic surgery. Yeah, so that can be an issue. If something is bleeding and if it gets frozen at that point of time, it can be an issue. That can be an issue with laparoscopic surgery also, where there are certain things where the pictures goes off sometimes because of electronical issues, or when there is bleeding, the blood comes onto the camera and you can't see anything, even with the laparoscopic camera also. So over a period of time, all these things look scary when we hear it for the first time. But when we experience doing a surgery, the control of bleeding, because of the magnification, even when the small bleeding starts, we have such a nice magnified vision and a very stable platform that we are able to manage small bleeds even more efficiently in robots than open surgery. Okay.
Are we not doing very well when we are doing manual surgery? Because we have seen 1950, 60 batch and all. We have seen only direct surgery.
Yes.
So we have never had any issue with the direct surgery.
Yeah.
Like a cesarean, we do
Yeah.
manually.
Yeah.
I don't think robots do cesarean.
No. I will tell you, there are certain questions we can answer as we go along also. I have two, excuse me, can you connect to the Wi-Fi? I have two very tiny little videos. Why minimally invasive surgery and why not open surgery? I will tell you with examples.
Finally, everything is human touch.
Yes, madam. Absolutely, you are right. Everything is human touch. We might touch directly, or I might touch with some instrument or with a robot, but it is always the human touch.
Expertise is very important.
Expertise is very important. The robot is never going to speak to the patient and reassure them. It is only us, we have to speak to the patient and reassure them. Yeah.
What about the duration of the
Does it reduce? She wants to know whether robotic surgery reduce the duration of the surgery.
Yes. Yes. For example, I used to do the laparoscopic low anterior resection. Laparoscopically, initially it took me 6 hours. Then I improved up to 4 hours using the laparoscope when I started the robotics. When I first started using the robot again also took about 6 hours for the low anterior resection surgery. Now with more experience, I have come down to 3 hours. So which is even better than laparoscopic surgery. So as we gain more experience, it is definitely saving time. But in the initial phases, everybody is always worried about the initial phase. okay, robot, we have to dock the robot, that will take a long time, and then de-dock the robot, and then if I'm operating in one quadrant and I'm going to the other quadrant, there is nothing called de-docking or anything in open surgery. You will ask the assistant to retract here and then retract here, and then you proceed with surgery. Whereas with the robot, if the robot is looking in this way, if I have to operate in this quadrant, for example, colectomy, once I have mobilized the left colon, now I have to go to the right colon. Then I have to de-dock the robot and then redock it to see towards the right side. So all these, everybody thinks initially, oh, all this is going to take time. But yeah, that is always the case when we start in the early stage of our career. But as we get more experienced, definitely with respect to low anterior resection, definitely the robot is faster than laparoscopic surgery. I can definitely say. Keyhole, yes. Both laparoscopic surgery and robotic surgery, they both can be called as a keyhole surgery, where we make small holes, only ports. So that principle is exactly the same. Whether laparoscopic or robotic, the principle of inserting small ports, 5 mm port, 10 mm port, is exactly the same. So how we do the procedure inside is what is making the difference. In hospital, yeah. Guest,
Residency.
Guest at Wi-Fi, guest at towers.
Towers.
Correct. எங்கேயோ போகுது, வேணா நம்ம ஃபோன்லேயே போட்டுக்க வேண்டியதுதானே. இதுலேயே சிக்னல் நல்லா தான் இருக்கு, இதுலேயே போட்டுக்கலாம். அது இருந்ததுன்னா கொஞ்சம் ஃபாஸ்ட்டாக இருக்கும்னு பார்த்தேன். Correct. Okay. I think we are all sorted now, so we can go ahead with the presentation. Okay. Okay, so I bring greetings from the Apollo Proton Cancer Center, which is in Tharamani in Chennai. And we are a comprehensive cancer center. And whatever I'm going to present has all been the work done at the Apollo Proton Cancer Center. So we can say the surgery is definitely a violent profession. All of you surgeons in the crowd might know how many assaults we make on the patient, how much we make the patient to bleed, and then how much tissues we cut. I think even though it's all in a controlled fashion, in a sense we can say it is definitely a violent profession. So just an ancient surgery, bringing it into perspective. In those days, the surgery was performed by holding the patients. The patients have to be really held down by really strong men, and the patients were given either opium or some liquor or given some hypnosis for anesthesia. And screaming and thrashing is something was commonly heard from the operation theaters in the ancient times. And I don't know whether it's a pleasure or a unpleasant sensation of watching one's own operation. Some people used to have it. And as a result of all these things, infection and death was extremely common. And hence, some patients chose to die from their conditions or commit suicide rather than undergo an operation. I think, the mentality of some patients even now, when they come and when we say that, they need a surgery to fix the problem, the first question they ask is, is there any other treatment that can be available? Can you sort this out without doing an operation? So that fear, I think, is still there somewhere in the corner of the minds in every people. So this is, I want to play this video. It goes to the next one. Yeah, I will play a matter. Or just disconnect this for a minute. Because this, one minute. This is just a YouTube video I want to play, and that will give the answer regarding why we want to do minimally invasive surgery and not, why is slideshow is not coming here? I want to just play this. அது full slide show போட்டால் தான் அது hyperlink work ஆகும். இங்கே போயிடுச்சு. Okay. Yes. Okay, so this is a blast that happened in Lebanon. I don't know why it's not playing.
Highlight the whole thing and then.
It's coming now. So basically what we can say is it's a marketplace. Everybody is doing their shopping. Some vegetables are being sold and suddenly something explodes. They have targeted a single person to blast and to attack, and not even a single onion has fallen out of that cart. Not even single other vegetables has fallen. They have exactly targeted the person they want to target. So previously, if you want to do something like that, you have to throw a bomb here and then the whole place would have been. So this is the difference we get between minimally invasive surgery and maximally invasive surgery. Huh? No, this was the pager blast. It was everywhere in the news. Basically what Israel has done, the people in Lebanon, the extremist people, they have bought pagers from a certain company, from Taiwan or something, and they bought all that to do some anti-Israel activities. Okay, they were using the pager. So all the people who are doing, some 2,000, 3,000 people are having this pager bought from Taiwan. What Israel has done is introduce a chip into that particular pager. During the manufacturing itself, they have infiltrated into the manufacturing place. They have introduced a certain chip, and when a particular code was sent to all these pagers, they all exploded. So all the 3,000 people who were having that specific pager with the chip inserted, the Israel, they just sent a code to all those pagers and made that to blast. So that was how. This is how the wars are being fought now. How precisely the wars are being fought, you can see. So this is the precision which we also use in minimally invasive surgery. See, battlefield, big battlefield, and dropping a bomb, damage everywhere. That is similar to open surgery, where we make a cut from here to here. So if we make a small 5 mm cut 10 mm cut there and do whatever we need inside, then that is the minimally invasive, minimal damage. See, because maximum complications happen because of the access, because of the wound infection, the wound dehiscence, burst abdomen, so all those things. So all those things we are avoiding by, so this is another example of the same war in the Middle East. Once again, it is taking time, where they wanted to target one particular building, and so they fired a missile into that particular building. All the other buildings are absolutely fine. Only the building which they wanted to get damaged got damaged in this attack. So after the missile went and hit this particular building. So because it's taking time, we will go to the next slide. Because it's frozen, because it's trying to download that.
This was happening in Ukraine.
Yeah. So all these, the wars are not fought on the battlefields. The wars are fought like this with a precision. All these missile attacks all happen with targeted attacks. That is what we can say. So we can say we do targeted surgery also with minimal damage to the as a result of the invasion. இது மட்டும் அடுத்த ஸ்லைடு போய்க்கலாம், இது வரலினாலும் பரவாயில்ல. க்ளோஸ் பண்ணிட்டு So from now on, I am not going to rely on the internet. So it's going to be smooth from now on. Okay, so this is where we left. Okay, so இதுல வீடியோ இருக்கு, வீடியோ ப்ளே பண்றது. ஸ்லைட் ஷோன் வருது, இதை எடுத்துடலாம் ப்ளஸ் ஆன. இல்லை இதில் வீடியோ இருக்குது, வீடியோ ப்ளே ஆகணும். ஸ்லைட்ஸ் மட்டும் சார் காட்டுது. This is just the abdomen actually. ஏன் ஸ்லைட் ஷோ வர மாட்டேங்குது? இருங்க. Okay. Yeah. So this is a huge tumor in the upper abdomen, which is involving the liver also. So this whole thing is the tumor. So this whole thing is the tumor, and then there is another part of the tumor which is occupying almost the whole of the abdomen and extending into the pelvis also. So this is the kind of situation where you can't do robotics, you can't do laparoscopic surgery also. So you can look at the size of the tumor. This was a 20 centimeter, that was 120 centimeter in the lower abdomen, another 20 centimeter tumor on the upper abdomen. So we can't manage this by laparoscopic or robotic surgery. So still there is a place for open surgery. Not everything can be replaced by, this was the laparotomy that was done. Big laparotomy incision was made from the Ziphy sternum to the pubic symphysis, and then this was 3 kg and this was 2 kg tumor. So these things have to be done by open surgery. So open surgery still has its own place. But what's the problem with open surgery? So the problem is we get big wounds, even bigger wounds than this. This is only showing a lower than the umbilicus. Sometimes we do from the xiphisternum to the pubis. Wound dehiscence can happen like this as a result of wound infections, and even sometimes burst abdomen, bowel might come through. And then hypertrophic scar, severe cosmetic disfigurement can happen because of scars like this. And even if it heals initially well, if the sutures in the abdomen gives way later on after 1 year or 1.5 years, they can form an big incisional hernia like this. So there are lots of problems with open surgery. Yes, we have to use it whenever we can't use any other means. But if we can avoid open surgery, and if we can avoid open surgery as much as possible, the damage will also be less. So when we started doing the minimal access surgery, we started it somewhere in the mid 1980s. It started off with a laparoscopic surgery, first for diagnostic purposes, and then it was used therapeutically also. For example, laparoscopic surgery for cholecystectomy was first done in 1987, and in the US, it starts in 1987. And by 1992, that is within 5 years, 75% of all cholecystectomies were being done laparoscopically. So that is how fast it took off. But then it has always been a problem. It didn't take off so easily when it comes to malignancies, because there were a lot of criticisms regarding using minimally invasive surgery for cancers. So we started off with the laparoscopic surgery. A further advancement of laparoscopic surgery, rather than making multiple holes, let us make a single hole and then do the whole surgery. This is called single incision laparoscopic surgery. Then came the robotic surgery. So robotic surgery has been in use since the late 90s. It was in around 1998 time that the robotic surgery, a transatlantic surgery, was performed with between United States and France, so that much early itself. But then it was only as a experimental thing, but it did not become a reality after that. But of late, in the last 4 or 5 years, robotic telesurgery is being performed, and it is being performed commonly in China, and it is soon coming to India as well. And we are also putting some efforts into bringing a robotic telesurgery here. So this is one further advancement of laparoscopic surgery, where some artificial intelligence is built into a laparoscopic instrument. This is an instrument used in laparoscopic surgery, but to make it behave like a robotic instrument, we are doing certain things, attaching a mini robot to this laparoscopic instrument to make this instrument behave like a robot. And then even more advancement of the robotic surgery is the single port robotic surgery. So here, even in robotic surgery, we make multiple holes. Here, this robot will just make a single hole, and through which all the ports will be there, and the whole operation can be done by single port. This is currently not available in India. All these are available in India, but this is the only one not available in India, but it is being performed. This is called Da Vinci SP, single port, and it is being performed in the United States already. So what is the advantage of minimally invasive surgery? What is the patient experience. Because the patient has smaller sized wounds, reduced post-operative pain, and because of reduced post-operative pain, they are mobilized early, and because they are mobilized early and because the patients are active, their bowel also becomes active. Bowel functions return earlier. As a result of that, they are staying for a shorter time in the hospital. Fewer wound complications like wound infection. Things like wound infection are almost like non-existent nowadays because all are tiny little holes. Definitely improved cosmesis is there, and overall cost, we can say it is reduced because there is shorter hospital stay, fewer complications. If you take everything into perspective, then we can confidently say that even minimally invasive surgery is cost effective. So this applies for both robotic as well as laparoscopic surgery. When I say minimally invasive, it applies to both lap as well as robot. So what is the surgeon's experience? So I was telling you about the patient experience. So for the surgeon, because we see with the magnification, so the camera is inserted and we see everything with the magnification, and we can even adjust the magnification. Because of the magnified view, sometimes even a 3-dimensional view, 4K, 8K views, it has definitely improved the knowledge of anatomy. The tissue planes are even more visible, definitely more visible than what was visible during open surgery. It allows precise dissection in the precise tissue planes, and the surgical assistant could assist and anticipate steps more effectively, because even the surgical assistant is also seeing through the same screen. He knows exactly what is going on, whereas an assistant in open surgery, if they put their head inside to see what's going on, they will block the view to the surgeon, and their only thing to do was only to hold the retractor. So it keeps the assistant more interested, and it helps training them more easily also. It keeps the surgical audience interested as they get the same view as a surgeon. The audience can be even as big as this, because in some conferences we do live surgery also, where the same view that the surgeon gets, the whole audience can also get, and it can be displayed on the big screen there. As a result of that, education is improved. Video recording, this is another thing. Recording an open surgery was very difficult, where somebody has to stand there, move here and there, still they won't get the best video in open surgery. Whereas in minimally invasive surgery, once it gets automatically recorded, at the end of the surgery, I have to just insert my pen drive and get the whole recording of the surgery, and I can edit it and show it in conferences, show it in meetings like this. And this, it's not only for educational purpose, it provides documentation also. It also provides opportunity for technological and technical innovations, which we have seen a lot in minimally invasive surgery. That was generally about minimally invasive surgery. How about minimally invasive surgery in cancer? It was first definitely met with skepticism. First, the criticism used to be like the cancer has to be dealt with by making big incisions, by seeing the tumor properly, by having a feel of the tumor. And if you make small holes, and if you put gas inside the abdomen, and when the gas comes out, all the port sites will get seeded with cancer cells, and it will cause port site metastasis, was a big criticism. So the early concern was minimally invasive surgery violated the oncological principles and caused a greater number of wound recurrences. But it was a concern without documented evidence. But favorable outcomes such as reduced hospitalization, improved recovery time, and reduced complications is clearly established. So only after that, laparoscopic cancer surgery was being more commonly used, and then after that, after doing all the cancer surgeries laparoscopically, long-term survival rates were found to be similar to open surgery. So it was only at that point it came to be accepted. So this was the start of we can say minimally invasive surgery for cancers. So this is the first ever publication of a laparoscopic colonic surgery which included colon cancers and rectal cancers also. It was published by Jacobs et al. From the United States in 1991. This was the first ever paper which said that operating cancers is feasible by using minimally invasive surgery. And since then there has been multiple number of publications. I don't want to go into each one in detail. So this is for gastric cancer. So there is more than enough evidences to say that laparoscopy is advantageous in gastric cancer. And then the next one is about colorectal cancer. Various randomized controlled trials, multi-center trials have all established it beyond any doubt that the laparoscopic surgery is, in terms of survival, it is as good, but with better short-term outcomes compared to open surgery. So after that, it got worldwide acceptance. So to start with, I'll just show you the laparoscopic surgery. This is a laparoscopic right hemicolectomy, which I performed at the Apollo Proton Cancer Center. So this is the retroperitoneal dissection I initially do to lift up the mesentery of the right colon. So that is creating, this is the retroperitoneal plane. I am pushing all the kidney, ureters, gonadal vessels all posteriorly. The duodenum is also pushed posteriorly. That's the head of the pancreas coming there, separating the mesocolon from the head of the pancreas also. And now coming more anteriorly towards the vessels, those are the ileocolic vessels. So ileocolic vessels are separated, artery and vein are separately clipped, and then the dissection is proceeded towards the transverse colon. So this is the left branch of the middle colic and this is the right branch of the middle colic. So I go in between, so that for a formal right hemicolectomy, I take the right branch and not the left branch. Right branch and all the vessels along with that will be taken. So the vessels which we will come across, the major vessel will be the ileocolic vessel, which was already clipped. Then the right colic vessel will be there, and the right branch of the middle colic. Once all those vessels are taken, superior dissection is done to release it from the hepatic flexure. Hepatic flexure mobilization is being done there. Care needs to be taken not to injure the gallbladder here. That's the kidney posteriorly that we can see with the Gerota's fascia on top. This is harmonic. I'm using a harmonic energy source to do the dissection here. So the complete right colon is mobilized and you can see all the structures in the retroperitoneum. So I will show you one by one. That is the common iliac artery continuing as the external iliac. That's the ureter, which you can see. That's the IVC, the big vessel there going under the duodenum there. Then the gonadal vessels there, the psoas muscle, and that is the kidney. So that's all the vessels that have been clipped. Ileocolic, right colic, and then a small incision is made just around the umbilicus, a 3 to 4 centimeter incision. Mobilized colon is all delivered out, and side to side stapled anastomosis is done. There are two ways of doing anastomosis. One is we take it out and then do it extracorporeally, and the other is doing the anastomosis within the abdomen itself, and then reinforced, and then the anastomosed bowel is pushed back inside. So this is all the patient has at the end of the procedure. So that is about a 4 centimeter wound just around the umbilicus there. 5 mm port here, another 5 mm port, and a 10 mm port here, and then another 5 mm port there. So these are the only wounds that have been created during the surgery. one port was inserted at the umbilicus, but that has been converted into the specimen extraction site also. So this is a patient, another case of laparoscopic surgery. This is a patient who had low rectal cancer, and incidentally on the PET CT, staging PET CT was also found to have a kidney tumor. So these are the the inferior mesenteric artery and vein being ligated, medial dissection being done, and that is the lateral dissection and release. So the whole colon is mobilized and released from the splenic flexure also, which is very important for the anastomosis. And then the dissection proceeds towards the pelvis. That is the mesorectal dissection. So I'm the laparoscopic surgery so that after that robotic videos, and you can place things in perspective regarding how the visualization is, how the instruments are, so that you can appreciate the difference.
Where is the camera?
Where is the camera?
The camera is in the... How is it taking?
My assistant is holding the camera. Through my assistant, he is called as the camera surgeon. He holds the camera. So somebody else has to hold the camera when it comes to laparoscopic surgery.
Nothing in this unit which has a camera.
No. So I am totally dependent. So we are coming to the partial nephrectomy part because of the kidney tumor. So this is one disadvantage with the laparoscopic surgery. The assistant holds the camera and he or she may not show exactly the view I want. So that is the kidney tumor being removed and hemostasis being done.
Clips are left like that inside.
Clips are left. Those are plastic clips and they are just left inside.
They're not biodegradable.
They are not biodegradable. They remain there for life. So this is for hemostasis of the kidney, and then the control of the kidney vessels is all released, and then the dissection proceeds for the anterior resection for the rectal cancer.
There is no rejection of the clips, sir.
Rejection of the clips, madam? No. We never see any such situation. This is just a plastic material. I don't know exactly what the composition is, but yes, madam. Yeah.
Is it pliable to make a...
Yeah.
No.
You mean
It should be pliable, only then you can make a knot.
we don't make a knot with the clip.
How are you keeping it?
I will show you better with how the clip works. I will show you better with another laparoscopic video.
I think you should know a lot of anatomy for this.
Yeah, I mean because we see it in good magnification. This is the problem in the pelvis. In open surgery or sometimes even with the minimally invasive surgery, the vision we get in the pelvis, particularly if it is an obese male with a narrow pelvis, the vision we get is very poor. That is where the robotic surgery scores over all the other forms of surgery. So this is the final anastomosis that is being made, and drain is placed in the pelvis, and I am marking the small bowel because it's a very low anastomosis. I will be bringing out a defunctioning ileostomy for this patient. Some rings are placed, so this is quite similar to that. You will get a much better view when I show the laparoscopic how exactly the clips are working. So this is a parastomal hernia of a patient who had a cancer surgery a few years back but developed a symptomatic parastomal hernia which we had to operate. So today I will just show you one video of one of the complications of a cancer surgery also. That is a complication of making a stoma. The risk of parastomal hernia is always there. but we operate on parastomal hernias only if it becomes symptomatic. This patient had a urostomy, that is an ileal conduit after a bladder surgery, and the ileal conduit was getting blocked because of this hernia. Otherwise, I would not be operating on this parastomal hernia. So much momentum got stuck in the within the parastomal hernial sac. So I release all the momentum and I release all the bowel adhesions also. So before I start doing the repair, only the defect has to be there, and then one bowel loop going into the defect. So that is the bowel going for the urostomy. So now closure of the defect. In this particular kind of situation, we can't close the whole defect because this is for a stoma. So I have to be very careful that I don't make it loose, too loose or too tight. So I'm just checking how snug it is, because if I make one more bite, it will compromise the blood supply to the ileal loop there. Yeah, I mean, it's all stitching skills, cutting skills. We have to be a good tailor. Initially it was all the barbers who did the surgery because of the hair cutting experience. They became the first surgeons, actually, the barbers. Even in Wales, where I worked for 2 years, the Surgeons Association in Wales is called as Welsh Barbers Society. So the closure of the defect is finished, and then the next thing I have to do is take this suture out and then place a mesh inside. So now doing cancer surgery also involves managing certain side effects and complications of cancer surgery also. So we have to be experts in doing these kind of repairs. So this is called a keyhole mesh repair, where the mesh is cut to give way for this loop of stoma bowel going out as a stoma. So the mesh is fixed on all sides. So more than cancer surgery, this is typical of a hernia surgery, and this is the principle we use for most of the ventral hernias. So it is being fixed by a combination of takers and sutures. So finally, whatever peritoneum is there to cover the mesh, we cover and then take the gas out and finish the operation. Coming to the robotic surgery. So how did the robotic surgery all start? Why was a robot needed? So they thought, cardiac surgery is very difficult surgery to perform open. So we need some kind of help to precisely perform cardiac surgery. So the robot was first, efforts went into making a robot to assist in surgery because of cardiac. So it was actually aimed for the heart. But then the cardiac surgeons didn't take it up in a big way. They kept on ignoring it. But the urologists first took up the prostate, and they found that for prostate surgery, the robot was becoming very useful. So the urologists are the first ones who took up the robotic surgery in a big way. And after that, the gastrosurgeons, now the thoracic surgeons, and the cardiac surgeons are now slowly coming into the picture. So what advantage do we have with robotics? This is in comparison to laparoscopic surgery. 3D visualization. So whatever laparoscopic surgery I was showing you was 2D visualization. The 3D visualization is inbuilt into all the robots. And endo-wristed instruments, which you will see as we go along, because the instruments can turn like our wrists. Stabilization of the tremor. You can see some shaking either with the camera or with the instruments in laparoscopic surgery, but you won't see any tremor or shaking in the robotic surgery. Motion scaling can be adjusted, especially for people with the tremor, scaling. If I do 2 centimeter movement here, only 1 centimeter movement has to go inside the abdomen. I can make settings like that so that I am more precise. So that is called as the motion scaling. Reduced operator fatigue. So I am not standing by the side of the patient and then holding the instruments in an uncomfortable manner. Sometimes I have to bend like this during laparoscopic surgery, whereas I am comfortably sitting on a chair and doing the operation comfortably in robotic surgery. So reduced operator fatigue and improved ergonomics because of all the other things, the ergonomics has improved as well. So what is the current evidence we have for various gastrointestinal oncosurgery? So starting with the esophagectomy. So there was a robot trial which was between robotic and open esophagectomy, and it showed that the robotic arm had reduced post-operative complications. They had lower post-operative pain, better functional recovery, and then the robotic was compared with the laparoscopy also, and still it showed a lower conversion rate to open, lower margin positivity by using the robot, and better lymph node harvest was seen in robotic esophagectomy. So it has come to be established beyond doubt in esophageal cancer surgery that robot is better than laparoscopic surgery or open. But that is not the case with the gastrectomy. So open gastrectomy versus robotic, they say there is a longer operating time, significantly longer operating time in robotic gastrectomy. And comparison of laparoscopic gastrectomy versus robotic, once again they say there is a longer operating time in robotic gastrectomy. So currently there is no verdict yet on laparoscopy versus robot as far as gastrectomy is concerned, but it could change in the future. Robotic liver pancreas surgery. The utilization of the robot is continuing to increase. Currently, there is no conclusive evidence for robotic superiority in HPB surgery. And more blood loss has been seen with robotic hepatectomy, and majority of liver resections are still being performed open only. So how about colorectal surgery? Robotic versus open. This is from Dr. Somashekar from Bangalore. He showed reduced length of stay and reduced blood loss with equivalent oncological outcomes by performing robotic colorectal surgery, and similar results was shown in other countries as well, and as recent as 2023, and so it was established beyond doubt that robotic was superior to open colorectal cancer surgery. How does it fare when it is compared with the laparoscopy? A large database analysis from the United States showed that robotic colectomy is associated with a shorter length of stay, lower conversion, higher lymph node harvest, and with a slightly or longer operating time. So then came the ROLAR trial, and more recently the REAL trial. So when you read the ROLAR trial said that there is no advantage of performing robotic surgery. They compared robotic with laparoscopic and said conclusion is no advantage. But there was a problem with that study where everybody who did laparoscopic surgery was very experienced laparoscopic surgeons, whereas the persons who performed the robotic surgery in that study were in the beginning of their career. So that is the reason why no advantage was seen with the robotic surgery. But the more recent REAL trial, once again, it has also established that robotic colorectal surgery is far superior than laparoscopic colorectal surgery.
Doing a lot of robotic surgeries, after 100 cases, you become well versed.
Yes, because some trials are
100 people are guinea pigs for you.
Yeah. I think that applies when a new medicine comes. When we give the medicine also, then we can call the patient as guinea pig. So
all trials are gone.
Yeah.
Finally,
That is the basis of study. Study of any medicine.
No,
Yeah.
medicine, oral medication, they do the trial and then come to us.
Yeah, yeah.
But here the surgeon does the trial and can get
But a lot of safety mechanisms are built into surgery also. So,
best thing is to ask a robotic how many cases is done.
so I will show you two robotic surgeries here. The robotic right hemicolectomy. You can compare it with the previous video I shown of the how stable the camera is, because the camera is adjusted by the surgeon himself. So how steady the instruments are, no tremor, the stableness of the camera is really impressive, because when somebody is holding the camera, that micro shakes can be seen all the time. So that even micro shakes are not there. So that is the reason why the pictures are looking as if they are very, very clear here. I mean, just imagine you are seeing it in 2D.
This section is very,
Yeah.
very neat.
Yeah, because the vision is good and magnification is good. In fact, the surgeon sees this in 3D view, even better view than what we can see here. So that is the dissection which is being performed near the duodenum also. And once this is completed, a gauze is placed and the dissection is continued to take the vessels. Little strand by strand, we don't need to be very fast at all. If we are very precise and even do it slowly, still the operation gets finished quite quickly if we don't. This is the clip that we use. This, we call it as a hemolock clip. You can see that there is a slot at the end where it clicks and it will hold on to itself, it sticks. Yeah. So you can see this is the advantage of endo-wristed instruments. See this wrist, because of this wristed instrument, I can turn the scissor in such a way it is favorable for me to do the dissection. Whereas a laparoscopic scissor will only be straight. It can open and close, but it cannot bend like this. Yes. So we can bend it like a parrot beak. So that is the originality means.
The abdomen, what originally there's so much of covers, like plastic covers, everything goes.
But the problem is the cancer. We have to remove the cancer, so we pay a certain price. But we try to minimize the collateral damage as much as we can by doing this kind of precision surgery. This was a branch of the gastrocolic trunk that I'm just clipping it. You can even see the wristed clip applicator. So, and finally, the remaining part is going to be the same, where I make a tiny little incision, 3 or 4 centimeter incision, everything is mobilized now. I take it out and do the anastomosis. So this is a robotic low anterior resection. So that is the dissection. We start with the medial dissection. And because of the precision with which we see these tissue planes, nerve preservation becomes a major advantage when it comes to rectal surgery, because there are a lot of nerves, the hypogastric nerves, inferior hypogastric plexus. So you can see how I am able to bend it. So you can very well see the wristed clip applicator, whereas in laparoscopy I will be using a straight clip applicator. It won't bend like this. So how close I'm just keeping my camera right next to the vessel and then clipping it with so much precision that not many things go wrong during this because of the vision we get.
Even you get the alarm if you are going wrong.
Yes, there are certain alarms also built into the robot. When it is getting frozen, then alarm comes out. So that is the beginning of the pelvic dissection. Because of this wristed instrument which is bending, I can use it very nicely like a retractor. Whereas the straight instruments, the laparoscopic instruments, will dig into the mesorectum. The intactness of this mesorectum is very important for the pathologist to report. So all this, when we are in the correct plane, all this loose areolar tissue is clearly seen, and we go in the perfectly correct plane. Even in laparoscopic surgery, I was using a harmonic, which you might have seen. Here I am not using any high energy instrument. I am using only the monopolar scissor here, and it is a bipolar grasper in my left hand. I use it both as a grasper, and when there is a little bit more bleeding, I use the bipolar for hemostasis. Hardly we see any blood during these procedures when we are going in the correct plane. So our average blood loss during these surgeries is probably somewhere between 5 to 10 ml at the most. So that is the blood transfusion is never done, almost never done, unless the patient's hemoglobin is like 7 or 8 during the surgery. Then we give a unit. I can't remember when I last gave a transfusion to a patient because there is too much bleeding on the table. Robotic, there are certain special guidelines that the manufacturer recommends, but it is not a very complicated thing. Yes, madam. Each instrument, some of the instruments are built for 12 uses. Some of the instruments are like the staplers are built for 3 uses, and there is no use and throw instruments in robot. We reuse it. Yeah, yes, madam. In robot, nothing is, even just 12 uses means that itself costs a lot. Yeah. Yeah. So this is the vision we get with the robotic surgery. If you compare with the previous laparoscopic surgery, the kind of vision we got in both are male patients actually of similar BMI, but the vision is much better. So this is a robotic stapler. This has been introduced only in the most latest version of the Da Vinci stapler, that is the Da Vinci Xi. So we can use the stapler to divide the rectum distally.
You do the sterilization like any other instrument?
Like any other instrument only. But certain guidelines has to be followed not to damage the instruments, because at least 12 uses has to come, otherwise it becomes very expensive.
Normally, what's the cost of the instrument?
Cost of the instrument per use for one patient, for one particular instrument, it comes to around 12,000 rupees. If I use the scissor for one patient, it comes to about 12,000 rupees. So the cost of the instrument will be actually 1.5 lakhs. But I use it for 12 patients, so the divided cost goes to the patient.
Even the scissors for 12 patients alone.
Yeah, yeah.
Then it becomes blunt.
We don't use it. The manufacturer does not recommend using it beyond that. It is programmed. Artificial intelligence is built into it, where if the 12th use is done, the 13th use it doesn't work. It doesn't work. So finally, the drainage tube is placed, and similar to laparoscopic surgery, this is exactly the same patient, where this is the specimen retrieval site, and these are 1, 2, 3, 4 ports that we have used to do this whole robotic low anterior resection surgery. Assistant is required, madam, because assistant sits at the trained staff. It is only the surgeon who sits in the console. This is robotic surgery. I am sitting in the console, which is in one corner of the room, but the patient is lying on the operating table. The scrub nurse is next to the patient, and there is one of my assistants who is next to the patient, because into one of the ports I am using the scissor, and once I am dissected with the vessels, then I am using the clip. Okay, so somebody has to take the scissor out and introduce the clip applicator. So for that, the nursing staff and my surgical assistant help with that. And I am looking into the 3D screen, but there is another 2D screen right next to the patient where they also see exactly what is going on. This is just to show the ergonomics. While I am operating robotic surgery, I am sitting down comfortably like this. I am resting my elbows on this thing, and this is my this is the movement that goes. So you can see that I am sitting comfortably, whereas when I am doing laparoscopic surgery, I am at the side patient's bedside. I am using the instruments, and sometimes I have to go into abnormal positions and get back pain at the end of the procedure. GA, madam. As usual, like any other operation, we usually do robotic or laparoscopic. The anesthesia is exactly how we do laparoscopy, because always when we put pneumoperitoneum inside, we always tend to go for a GA. So this is one advantage where you can see two consoles there in the same operating room. So this is the consoles, and this is the operating table where the robotic arms go into each of the ports, and the scrub sister and the assistant will be sitting somewhere there next to the patient. So for the training purposes, they are using, some hospitals are using dual consoles, where when the senior surgeon wants to teach the junior surgeon, like driving, they have two controls for both the driver and the person sitting by the side. Yes, these all these robotic arms can be used by both these surgeons. When this surgeon is using it, this surgeon cannot use it. He has to stop, he has to take the fingers off the console, and then he can start. Both of them can't use at the same time. It is built into that. So now he sits there, both are getting exactly the same view, and he says, this is the tissue plane you have to cut. You can start dissecting.
When you talk here.
Yeah, there is a mic inbuilt into the system, where when I talk here, I have to give instructions to my assistant, the scrub sister, everybody. So there is a mic built into here on the right hand side. When I speak anything, it goes through the mic, and the whole room people hear that.
Painting and draping of the patient, the scrub sister takes over.
Painting, draping is done by the scrub sister or by the surgical assistant. And then the surgical assistant are always the ports or standard ports that we use. The surgical assistant, if he assists 3 or 4 cases, he will know exactly where to put the ports. So I will be at home when the patient is getting shifted to the operation theater. I will be at home. I can wake up from at that time, and then painting and draping is done, and then the assistant is there to introduce all the ports.
Painting and draping manual.
Manual only. And then the assistant surgeon inserts all the ports, and then all the instruments has to be inserted into the. Roughly this takes about, from the patient pushing into the theater, by the time we start, it takes about 45 minutes. So I go into the theater exactly when I have to sit on the console and start the operation. So we do the robotic part, sitting on the console like this. And then once all the dissection is finished, then it is a matter of extracting the specimen and doing the final anastomosis. So my assistant will be able to do the extraction of the specimen through the another hole, and then finally the anastomosis will be done. So I will be going to the bottom. My assistant will help me with engaging the anvil. So from the beginning to the end, I have not scrubbed at all. I'm not wearing I will be wearing a gloves only for the final stapler firing. But I am the one doing the main thing on the console. So I am telling you, it can happen like this. It doesn't always happen like that, but because even if my assistant is doing, I'm keeping a close watch on him, standing by the side. And when there is not enough hands, I watch in as well. So I'm just telling you that even a major surgery can be completed without the surgeon wearing a pair of gloves.
I've seen even for cardiac surgeries in Apollo, everything is done by the assistant. The cardiac surgeon will come only when he has to place the valves.
Yeah.
Exactly that time.
Yeah. So that they are fresh while doing the most crucial step of the procedure. So, what is the robotic superiority? So, we have seen quite a bit of videos. So, endo-wristed instruments, as you have seen, it gives 7 degrees of freedom. So, the wrist has 7 degrees of freedom. In the same way, a robotic instrument has 7 degrees of freedom, whereas a laparoscopic instrument only has 2 degrees of freedom. So, and tremor reduction is there, 3D vision is there, higher precision is there. Ergonomics is better for the surgeon is more comfortable during the procedure. So why should it matter for the patient that the surgeon is, if the surgeon is more comfortable, then it translates as a better outcome for the patient. So better functional outcome, because we are able to do, because of the very good vision, we are able to preserve the nerves in the pelvis. The nervi erigentes, the cavernous nerves, the hypogastric nerves, the inferior hypogastric plexus, all of these are preserved because of the better visualization we get with the robotics. In fact, we used to do the preservation better with the laparoscopy also, but it is done even better with the robotics. So just tiny clips, this is just to show how a scissor, we can use it like a shape like a parrot beak and do the dissection. So this is just a small clip for the clip applicator. You can see how endo-wristed, and I am turning it like this, because if it is straight, certain angles I will not be able to get. So I turn it exactly the angle which I need, and it goes in, because a lot of times in laparoscopic surgery, because it will go in only one particular angle, and it causes shearing of the vessel if I don't go in the correct angle, and bleeding has happened from major vessels like this. So that can be avoided in in robotic surgery. So this is how I'm in control of the camera here. I take the camera deep down into the pelvis and right next to the tissue that I have to cut, so that the vision we get is absolutely amazing with the robotic surgery. So this amount of precision, this kind of visualization we never had with open surgery. Open low anterior resection was mostly like a blind surgery. The surgeons used to put their hand in and put a scissor and then cut blindly, but because of their experience, they were able to cut into the correct planes. But in locally advanced cases, there used to be a lot of bleeding. But here, everything we are able to do under vision. So this is one of the high energy instruments. This is quite expensive actually. This a single use of this instrument costs 60,000 rupees. This is called as a vessel sealer. So very selectively we use this. Most of the colorectal procedures we are able to do without this high energy instrument, routine anterior resection, but only when we have to do like a total colectomy, when I have to cut through the mesocolon, that I use this vessel sealer. And then the stapler, this is called as the sure form stapler, and then it turns even and it rotates better than a laparoscopic stapler, and then I can take it as far deep into the pelvis, and the angulation helps. So distal rectal division is a very, very crucial part of a rectal cancer surgery, because this is where I get the clearance in low rectal cancers. So is the robot inferior? We saw a lot of things about the robotic superiority. So what is the inferiority of the robot? Yes, higher cost. Higher cost is because of lot of things, which I will show you. Even Dr. Kailash was asking me in the beginning whether the robotic surgery costs maybe double the amount of laparoscopic surgery. It's not exactly the case. We charge about 2 lakh extra for a robotic case. For example, a laparoscopic low anterior resection, if it is costing 5.5 to 6 lakhs, the same thing in the robot, it costs 7.5 to 8 lakhs. So 25% increase in the cost, we can say. Not 25%, but it is exactly 2 lakhs. And when we use certain special instruments, it can go up to 2.25 lakhs extra.
Insurance packages for this also?
Package is not possible. But when I say it is like 5.5 to 6, because of all the bills, we have worked out how much. Currently in Apollo, we don't have a fixed tariff because some patients stay for 6 days, some patients stay for 4 days. In some operations are taking 6 hours, some operations are finished in 3 hours. So that because of that variability is there, we are not able to offer exact packages, but mostly it will fall within this range. And some are taking standard room, some are taking deluxe room. So higher cost is still a problem. But we have done certain things to improve on that factor. I will show you after this slide. Higher operative time, once again, both these are actually relative inferiority things, and this could turn out to be superiority in the future also.
How much operative insurance coverage percentage, how much they cover, sir?
For robotic cancer surgery, based on how much the assured sum is there, they
10 lakhs?
Not
There are
cancer.
10 lakhs will be covered.
yeah.
Ordinary surgeries, that's the
Robotic, if I do a robotic hernia surgery, they won't give. They will say it can be performed equally well with the laparoscopic surgery. So why do you want to use a robot? And then they will finally give the cost only applicable for a laparoscopic surgery. They will reduce the amount that they approve. Whereas in rectal cancer, it is accepted by insurance companies. Robotic surgery is better than laparoscopic surgery because the evidence is there, publications are there, and so depending upon the amount insured, they get the full cost also. Yeah. See, how do we examine the cost?
government application of bearing the cost for the imaging.
Government, madam.
Government bears the cost for the imaging and the LG.
Okay.
Surgery.
But that is not, I don't think that's have any applicability in the private institutions, I think. So how do we examine the cost? Because a lot of people say robotic costs too much, but all that cost has been taken from the robotic learning curve. Because in the robotic learning curve, the hospital has newly installed a 15 crore robot, so that installation cost is there, and then the surgeons are doing robot in the early stages, even though they will be experienced open surgeons and laparoscopic surgeons, so they will be able to perform the operation efficiently and safely, but they will take a lot of time. So that lot of time also goes into increasing the cost, because in private institutions every hour costs. So it is all based on the charges, because some part of installing the robot, the investment on the robot has to be recovered. So once the full cost is recovered, then it can become cheaper also. And the cost takes into account only the intraoperative things. If I am able to gain by reducing the length of stay, most of our patients, more than 90 to 95% of robotic low anterior resection patients are getting discharged on the 3rd or 4th post-operative day. 90 to 95%. Very few, the remaining go on the 5th day. So very rarely we have patients staying beyond that day. So that also has to take into consideration when we calculate the cost. So basically we have to look at the bigger picture, not just the robot alone.
So staying for minimum number of days, they increase the cost of the surgery.
No, it decreases.
It decreases the cost, the whole package for the patient.
Staying lesser number of days, the cost will come down.
Cost will come down. Yes, that's what I said. Because when somebody gives a package for robotic, for example, robotic anterior resection, the package is 8 lakhs. So if the cost comes down, we are able to easily meet, and then if my cost comes consistently below 8 lakhs, 7.5 lakhs, because of their stay is reduced, I can even reduce the tariff to 7.5 lakhs instead of 8 lakhs. So what have we done to reduce the cost in robotics? Yes, robotic cost is an issue. Even paying 2 lakhs or 2.5 lakhs extra for a patient, extra for a procedure is beyond the reach for certain patients, where we use the same instruments every time. Because if for some part of the dissection in the right hand I am using the scissor, and for other parts of the surgery if I am taking a hook, so that means I am using 2 instruments with my right hand. So the 2 instrument costs come. I have trained myself, and in our entire team we have trained ourselves in such a way we can finish a robotic anterior resection with dissection will be done only with the scissor in the right hand. So we have trained ourselves. That translates into cost saving for the patient also. So that is one way we reduce the cost for the patient. Using 2 robotic pods. If I totally there are 4 robotic pods. We routinely use 3 because 1 goes for the camera and 2 goes for the instrument, and then the 4th robotic arm where I can use another instrument becomes optional. So I have an assistant, a trainee with me. If I have to actively engage him in the operation, I put a laparoscopic port and ask him to do some retraction so that he is closely watching the operation. He is getting better training, and if I don't use 1 extra instrument and 1 extra port, I have savings of about 25,000 rupees. So that also we routinely use 2 robotic. If a surgery demands, if it is a too complex surgery, and if I have to use all the robotic arms, I will use it. But where I can avoid and save some money for the patient, I will save the money for the patient.
Installation charges also comes.
Yes, madam. Nowadays, there are a lot of robots being given to hospitals on like a rental basis. There is no upfront cost, but for each surgery performed, the hospital has to pay about 1.5 lakhs to the robot company for 1 case performed. So it is like taking the robot on a rent, and for each case they pay a rent to the company for a certain number of years.
It's like a toll gate.
Yes, madam. Because the upfront cost is avoided, lot of hospitals have installed the robot on this model. But the cost per patient will be high in this model, the rental model. Yeah. So we have to minimize unnecessary tools, because a lot of times in the beginning stages, people used to take a laparoscopic camera, see with a laparoscope first, see whether whether it will be easily done with the robot. We have to check whether we can proceed robotically or not. So people used to use a robotic camera, a laparoscopic camera, laparoscopic instruments that used to cost about 15 to 20,000 extra. Now we don't do that because we are more experienced with the robot. So with the robotic camera itself, we check whether we can proceed robotically or not, and if we can proceed robotically, we just continue doing it. We are not changing the laparoscope to the robotic. So that saves some money. Avoiding high energy devices. As I told you, the scissor on the right hand and the bipolar on the left hand, they don't cost much. Whereas if I use a high energy instrument like the vessel sealer, so you can compare using a scissor for 12,000 and using a vessel sealer for 60,000. So if I avoid using a vessel sealer, I save 48,000 for the patient. Because there is no bleeding at all, madam. If I go in the right planes, so if there is bleeding and if I need a vessel sealer, I will take it.
No, you cannot, in robotic, you cannot apply any other methodology of arresting the bleeding, excepting the robotic.
Only we have to use the robotic instruments only. Yeah, vessel sealer. So when we repeat the same thing again and again, because I repeat the same thing and again by using the scissor, I use the scissor again and again, I get so well trained with a single instrument alone. So we build efficiency, we become faster, we save money for the patient. This is what is very expensive, a half-hearted robotic use. Okay, let me see with the laparoscope first and see whether we can proceed or not. That itself is a half-hearted approach. And then second thing is there are a lot of reluctant robotic surgeons where early in their career, maybe the robotic surgery might take half an hour, 1 hour extra. They will lose patients at one point of time and they will go back to their laparoscopic surgery because they have more experience with that. So easily, a lot of surgeons I have seen, they convert quickly to laparoscopic surgery. Oh, this is not working robotically, let me convert to laparoscopic. When people use it half-heartedly, they are not going to become experts in robotic surgery, and hence in their hands, robot is going to become more expensive because the patient pays for both the laparoscopic instruments as well as the robotic because the procedure was performed half robotically and half laparoscopically. So in conclusion, open surgery is still the option, still the only option in certain situations where we saw a very big tumor and there is no space for any pneumoperitoneum. Laparoscopic surgery is well established in the last 3 decades. Can we say that robotic surgery will completely replace laparoscopic surgery? Probably not, because we have the diagnostic laparoscopy where we want to go inside. I don't want to do diagnostic robotics and spend 2 lakh extra. I would rather have and for small procedures like even that parastomal hernia and gallbladder surgeries. All these surgery, gallbladder surgeries takes less than 1 hour. All these parastomal hernias takes about 1 to 1.5 hours. So for these short surgeries, I don't want to increase the cost for the patient by using a robot where I can equally perform well with a laparoscopic surgery. So I don't think, for example, acute appendicitis, doing an appendicectomy, I don't think that is going to, robotics is going to replace laparoscopy in these kind of situations. But definitely it helps with cancer surgery because the precision with which we can do nodal dissection is amazing and the vascular dissection is amazing. So the robotic superiority with cancer surgery in the GI onco surgery is clearly established in these 2 cancers, esophageal and rectal cancer surgery. But that doesn't mean that in colon cancer surgery it is inferior. It is still not proven by studies yet, but the future the future will tell, the future studies will tell. This is as of the current status. High cost and longer operating time or the current limitations for robotic surgery, but both are relative things. So both oncological and functional outcome are important because the functional outcome is where the robotic surgery scores by doing more nerve preservation, particularly in the pelvis. That is why in rectum, it is probably in another 5-10 years time, we won't be doing any laparoscopic surgery also. We will do all rectums only by robot. That is what I feel, because that is where the functional, laparoscopy also can give an equivalent oncological outcome, but functional outcome is definitely better with robotic surgery. So that is where it scores. So that is our team. Dr. Kailash can see his friend, Dr. Venki Munikrishnan also. So this is the full robotic surgery team. Dr. Balamurugan, he is an upper GI surgeon. Myself and Venki, we are both colorectal surgeons. Dr. Sudeep Taswain is also an upper GI surgeon, and Dr. Anand Murugesan is our anesthetist. So this was the team's performance in 2024. 200 major GI oncology procedures were completed, and among that, the colorectal cancer alone, we performed 130 robotic colorectal cancer procedures in 2024. So we can say that our team runs the world's most cost efficient, because we did some thinking into in what all the ways we can save money for the patient, and we can confidently say that we run the world's most cost efficient robotic GI surgery program. So we offer fellowship in robotic colorectal surgery also between the Apollo Proton Cancer Center and the Apollo Main Hospital within our team. If there are any candidates, currently we have a fellow working with us, but it is for a period of 1 year. So if there are new candidates who are interested, they can approach us for the next year. So
the learning will be 1 lakh per month.
I mean, it is not only the learning, but it is also, they also work as like a senior registrar. See, they take care of the patients. It's not just observership. They will be the bedside assistant in all the surgeries, and they work like a senior registrar. We prefer to take either last year we had a post MCH person who worked with us, and currently we have a post MS experienced person who's with us doing this robotic program.
Is it called robo or robot?
Robo,
D is silent. Because everybody is saying robot.
I mean, both are being equally used. I think whatever somehow the surgeons, we are calling it, most of us call it as a robotic surgery. So when we say just the robot, you can either say robo or you can say robot, whichever. There is no fee, madam. They work as a senior registrar, and they for working with us, they earn 1 lakh per month. Yeah. Like any other instrument only. It's just like we have to, for example, we saw that scissor, we have to take the outer sheath out because some blood might have entered into the sheath. So all that joints has to be cleaned more thoroughly, because laparoscopic instrument doesn't have this much joints. So robotic instruments, those joints has to be cleaned more thoroughly. But otherwise, the sterilization procedure also. Cleaning is either autoclave or the steroid where ultrasonic radiation is being used. All that is applicable to these instruments also. Thank you very much for opportunity.
In very simple way you explained, sir. We all thought robotic is going to be big stuff.
Yeah.
Very simple. Excellent.
Thank you so much for giving us a good lecture.
Please give him a standing ovation so that you will enjoy it.
Just like a layman when you're asking you questions, sir.
I am most happy with all these questions.
Thank you very much, sir. In fact, we should thank Apollo Dayalan for giving this opportunity. In fact, please come, Dayalan. He has been very kind to us. Every month he calls me up and says, "Can I have a meeting?" So kind of them. Probably Apollo wants to educate the doctor fraternity on the newer concepts and things like that. So very happy, sir. We're thankful to you for that wonderful, simple presentation on robotics. In fact, I was really scared of robo, but now I'm no longer scared of robo. I mean, some points, all of us will have about 10 lakhs insurance. Most of us will have 10 lakhs insurance. More than 5 lakhs. Please honor yeah, give a big hand for Dayalan also, because he was so kind to organize it. Not only that, he arranged From Karnataka, several cases I referred to previous meeting.
Okay.
They have put them also.
Okay. You can always contact Dallin for any of these. He will take personal interest and take care of the case in Apollo. Okay. And most of our patients have insurance, so there shouldn't be any problem. Anything? Yeah. Okay. I think I'm audible. I thought I'm audible.
You are,
Yeah.
you are, sir.
Yeah. Good, sir. I think we can wind up now,
Yes,
sir. So, bye. Thank you very much for attending such large numbers. Thank you.
Thank you very much for being very interactive also. That made things go more smoothly also. And because the other speaker was not here, I was able to go leisurely, slowly. Yeah. Thank you.